I'd like to thank APOA for allowing me to give this talk. The Supine Correction Index predicts outcomes with bracing for adolescent idiopathic scoliosis. I have no disclosures. So as we know, AI's progression can be predicted by the cob angle and the bone age, but we also need to understand the flexibility of the curve, and in-brace correction influences the outcome for brace treatment. Now, in this study, we want to introduce the Supine Correction Index, which is a ratio between the correction rate and flexibility times 100%, to determine whether it can give you a standardized outcome to predict brace outcomes. Now, in this study, we included 207 patients from this prospective study of AI's patients undergoing underarm bracing. It is prospective cohort based on the SRS criteria for bracing, right? So essentially 20 to 40 degrees, there's no previous treatment, and they are reserved 0 to 2. Now, all of our patients had brace 1 for 20 hours a day with compliance via thermosensor bracing to make sure that all our patients do not have non-compliance leading to curve progression. And that's not related to actually the flexibility and the curve pattern. So we collected data including demographic information, age, sex, menarche, arm span, weight, height, BMI, scoliometer measurements of ATR. And on X-rays, we assessed the pre-brace X-ray standing, the supine X-ray, which we use to fabricate our braces, the in-brace X-ray immediately after brace fabrication, which is within around 2 weeks from the supine X-ray, and of course, the final outcome of X-ray. We use the outcome as in whether a patient is at weaning or whether they underwent surgery with curve progression. So on measurements for X-ray, various assessments were done on the coronal plane of the coronal cob, shoulder height, trunk shift listing, T1 tilt, various apical ratio, wedging, disangulation, and also the sagittal plane alignments. Now, these are the important equations that you need to take note. For flexibility assessment, we determine it as the pre-brace cob angle minus the supine cob angle over the pre-brace cob angle, while correction rate is the pre-brace cob angle minus the first in-brace cob angle over the pre-brace cob angle. And as I mentioned, the supine correction index is correction rate over flexibility. Now, curve progression was our main outcome, with more than 5 degrees versus baseline cob indicating there is progression. And we used a multivariate logistic regression with for any values less than 0.25 from a univariate analysis adjusted to the initial cob, RISR, curve type, menarche status, distal radius, and under classification, brace compliant, to make sure that we're only comparing the flexibility and in-brace correction. Now, we had 45 patients from our cohort that had curve progression, and the multivariate regression analysis showed that various factors such as sacropelvic incidence, but importantly, flexibility and correction with significant statistical analysis showing association with curve progression even after adjustment. And we found that less progression was obtained for patients who had flexibility of more than 18.1%, of a correction rate of more than 28.8%, and a supine correction index of 1.21. You can see here that these optimal cutoffs are generated with quite satisfactory AUC and sensitivity specificity analyses. So this is an example of using the SCI to predict regression. You can see this is a 12-year-old female with a cob angle around 33 degrees at RISR 0 from in the initial phase. And the supine X-ray, you can see here, showing a correction to 20 degrees. This shows a flexibility rate of 38.6 degrees. This is the first in-brace film showing you a 15.2 degree correction. So a correction rate of 54%, which yields a supine correction rate of 1.41. This indicates that the curve does not progress given the supine correction index, and the cob angle maintains at 30 degrees at skeletal maturity. So in conclusion, we found the flexibility of more than 18.1%, correction rate of more than 28.8% predicts better outcomes with less curve progression. And now we have a very easy to use supine correction index of 1.21. And as long as you have your curve has flexibility and correction rate leading to a supine correction index of more than this, will predict a lower risk of progression. So this is a very good tool for you to communicate with patients and prognosticate the outcomes with brace treatment. Thank you.